psychological emergencies and anemia in cancer care. Cancer diagnosis and treatment can lead to profound psychological distress. Nurses must recognize and intervene in psychological crises to promote emotional well-being and patient safety. Causes: a new diagnosis, fear of death, disfigurement or disability, treatment side effects, and loss of control can all trigger acute anxiety or panic attacks. Assessment: rapid breathing, palpitations, chest tightness, feeling of dread or doom, diaphoresis, tremors, and difficulty concentrating are key signs. Nursing interventions: remain calm and stay with the patient. Speak slowly and clearly. Encourage slow, deep breathing. Provide reassurance. Offer support groups, chaplaincy, or mental health referrals. Causes: loss of role, function, independence, chronic pain, fatigue, fear of recurrence or death, and body image changes such as mastectomy or colostomy can lead to depression or suicidal ideation. Assessment: look for withdrawal hopelessness, appetite or sleep changes, statements about death or being a burden, and non-adherence to treatment. Nursing interventions: screen using PHQ-9 or similar tools. Ask directly about suicidal thoughts. Notify the provider immediately if suicidal ideation is present. Ensure safety by removing sharps and other means of self-harm. Provide emotional support and referrals to psychiatry or counseling. So, let's talk about what can cause delirium or acute confusion in oncology patients. Some of the common causes include brain metastasis, electrolyte imbalances, certain medications like opioids and anticholinergics, infections, and hypoxia. When assessing a patient, you might notice a sudden onset of confusion and agitation. They may experience hallucinations and disorientation. Also, pay attention to signs of inattention and an altered sleep-wake cycle. As for nursing interventions, it's important to reorient the patient frequently using clocks and calendars. Reducing environmental stimuli can also help. Ensuring safety is crucial, so always implement fall precautions. Evaluate for underlying causes with labs and imaging, and administer antipsychotics like haloperidol if prescribed. Anemia is pretty common in cancer patients. This can be due to several reasons such as blood loss, bone marrow suppression, nutritional deficiencies, or chronic inflammation. Now, let's dive into iron deficiency anemia. The causes can include chronic blood loss, for example, from gastrointestinal tumors, nutritional deficiencies, or poor absorption, which might occur after gastric surgery. When assessing for iron deficiency anemia, look for symptoms like fatigue, pallor, and dyspnea. You might also notice glossitis, which is an inflamed tongue, brittle nails, and even pica, which is a craving for non-food items like ice or dirt. In terms of labs, you'll typically see low hemoglobin and hematocrit levels, low serum iron and ferritin, and an increased total iron binding capacity. For interventions, oral or IV iron supplements are commonly used. It's beneficial to take iron with vitamin C to enhance absorption. However, avoid taking iron with dairy, calcium, or antacids. Also, monitor for side effects like constipation and dark stools. All right, let's talk about vitamin B12 deficiency, also known as pernicious anemia. The main causes include a lack of intrinsic factor, which is pernicious anemia, gastric surgery, malabsorption issues like Crohn's or celiac disease, and a strict vegan diet. When it comes to assessment, you might notice fatigue and pallor. Neurologic symptoms such as paresthesia, ataxia, and memory loss can also be present. Additionally, a smooth, beefy red tongue, known as glossitis, is a key indicator. Lab results will typically show low hemoglobin and hematocrit levels, low B12, and a high mean corpuscular volume, indicating macrocytic anemia. For interventions, monthly intramuscular vitamin B12 injections are necessary if the intrinsic factor is absent. Oral B12 supplements can be used if the deficiency is mild or due to dietary causes. It's also important to monitor neurologic status regularly. Moving on to folic acid deficiency anemia. The causes include a poor diet, alcoholism, malabsorption conditions like celiac disease, and the use of certain chemotherapy drugs or anticonvulsants. The assessment is quite similar to B12 deficiency, but without the neurologic symptoms. You'll see fatigue, pallor, and glossitis. Lab tests will reveal low hemoglobin and hematocrit levels, low folate levels, and a high mean corpuscular volume, which means macrocytic anemia. For interventions, oral folic acid supplements are recommended. Encourage the intake of folate-rich foods such as leafy greens, citrus fruits, legumes, and fortified grains. And of course, monitor nutritional intake closely. Just a quick NCLEX reminder. Iron deficiency leads to microcytic anemia, while B12 and folate deficiencies result in macrocytic anemia. Always monitor for symptoms of hypoxia, like tachycardia and shortness of breath. If needed, intervene with oxygen, rest, and transfusions. Coming up in cancer complications and oncologic emergencies, including tumor lysis syndrome, superior vena cava syndrome, spinal cord compression, hypercalcemia of malignancy, SIADH, and disseminated intravascular coagulation, or DIC. Would you like to move straight into Part 7, or shall I prep a complete PDF or handout of Parts 1 through 6 so far? These are life-threatening complications that require immediate nursing assessment and intervention. Early recognition can save a life and help you score key points on the NCLEX. Tumor lysis syndrome occurs when massive numbers of cancer cells die, especially after chemotherapy in leukemias and lymphomas, releasing intracellular contents into the bloodstream. The hallmark electrolyte imbalances are hyperkalemia, hypophosphatemia, hypocalcemia, and hyperuricemia. Assessment includes nausea, vomiting, muscle cramps, tingling tetany seizures, oliguria, renal failure, and cardiac dysrhythmias from hypokalemia. Interventions include hydration with IV fluids before and after chemotherapy, administering allopurinol to reduce uric acid, monitoring labs like potassium, calcium, uric acid, BUN, and creatinine, and treating imbalances with calcium gluconate, sodium, polystyrene, sulfonate, and insulin and glucose. In some cases, dialysis may be required. NCLEX tip: prevent tumor lysis syndrome by aggressive hydration and giving allopurinol before treatment begins. Superior vena cava syndrome, or SVCS, occurs due to the obstruction of the superior vena cava, often caused by a mediastinal tumor such as lung cancer or lymphoma. When assessing for SVCS, look for facial and neck swelling, periorbital edema, dyspnea, cough, and hoarseness. You may also notice distended neck and chest veins, and in later stages, cyanosis and increased intracranial pressure. Interventions include elevating the head of the bed, administering oxygen, corticosteroids, and diuretics, and preparing for radiation or stenting. It's also important to avoid using the upper extremities for IVs or blood pressure measurements. Spinal cord compression happens when a tumor compresses the spinal cord, which is common in cancers like breast, prostate, lung, and lymphoma with spinal metastasis. The first sign is often back pain, followed by weakness or numbness, loss of bowel or bladder control, and, if left untreated, paralysis. Interventions include administering immediate high-dose corticosteroids, using MRI or CT scans for diagnosis, and considering radiation or surgery to relieve the pressure. Always implement fall precautions and conduct regular neuro assessments. NCLEX tip: prioritize this patient. New back pain in cancer should never be ignored. Hypercalcemia of malignancy is common in breast lung and multiple myeloma due to bone destruction or paraneoplastic hormone production. For assessment, you might see fatigue and weakness, nausea, and constipation, confusion and lethargy, as well as bradycardia and a shortened QT interval. Lab results will show serum calcium levels greater than 10.5 milligrams per deciliter. Interventions include administering IV fluids to flush out calcium using loop diuretics like furosemide and bisphosphonates such as pamidronate. It's important to implement fall precautions and closely monitor ECG and neurostatus. PSI-ADH is often seen with small cell lung cancer and CNS tumors, leading to water retention and hyponatremia. For assessment, look for fluid overload signs like weight gain and edema. Hyponatremia symptoms such as confusion, headache, and seizures, as well as low urine output and concentrated urine. Interventions involve fluid restriction, administering hypertonic saline, specifically 3% NaCl if severe, and monitoring sodium levels and neurostatus. Seizure precautions are essential, and medications like democlocycline or vasopressin antagonists may be prescribed. DIC is a life-threatening complication where widespread clotting uses up all clotting factors, leading to severe bleeding. This can be triggered by sepsis, leukemia, or trauma. For assessment, you may notice bleeding from IV sites, gums, and nose, hematuria, petechiae, and bruising. Hypotension and tachycardia are common, and organ failure can occur from microthrombi. Lab results will show low platelets, prolonged PT and APTT, and elevated D-dimer levels. Interventions include treating the underlying cause, administering blood products such as platelets and fresh frozen plasma, monitoring for bleeding and shock, and avoiding invasive procedures. When faced with oncologic emergencies, here are the top priority actions. For tumor lysis syndrome, focus on hydration, labs, and allopurinol. In cases of superior vena cava syndrome, elevate the head of the bed, provide oxygen, and consider radiation. For spinal cord compression, administer high-dose steroids, perform neurochecks, and get an MRI. For hypercalcemia, use IV fluids, diuretics, and monitor ECG. In SIADH, restrict fluids and monitor sodium levels. Finally, for DAC, stop the bleeding, replace clotting factors, and treat the underlying cause.